Chapter 11 Test Paper 6. Questions. Time, 3 hours. 1. A computed tomography, CT, chest is done in a 6-month-old girl with a history of premature birth, chronic lung disease, and MRSA pneumonia. It shows a large gas-containing, thin-walled cavity in the right lung, consistent with a pneumatocoel. All the following are true regarding a pneumatocoel, except A. They are gas-filled, thin-walled spaces surrounded by lung. B. They can be associated with lung contusion. C. Most pneumatocoels resolve spontaneously. D. Pneumatocoels do not cause mediastinal shift. E. They can have fluid levels. 2. A 58-year-old patient is reported to have a carcinoid tumor of the gastrointestinal GI tract on an abdominal computed tomography scan. What is the most common primary site of GI carcinoids? A. Stomach. B. Colon. C. Rectum. D. Small bowel. E. Appendix. 3. A 53-year-old man with history of hematuria, which shows a gel-like polypoid filling defect on cystoscopy, is sent for an MRI. The MRI shows a low T1 signal, heterogeneous T2 signal, central high and peripheral low lesion. On post-contrast T1WFS images, the peripheral portion enhances more than the central portion, resembling a ring-like pattern. What is the diagnosis? A. Endometriosis. O may result from positive pressure ventilation-related barotrauma and ingestion of caustic material, e.g. hydrocarbons. Post-infectious pneumatocoels most frequently complicate staphylococcal pneumonia and occur in infants. They typically appear within 1 week of onset of infection and most spontaneously disappear within weeks to months after the infection has resolved. Rarely, persistent pneumatocoels may require percutaneous catheter drainage or surgical management. Post-traumatic pneumatocoels result from blunt trauma. Such pneumatocoels are typically observed within hours of the trauma and spontaneously resolve within 3 weeks. They generally spare the lung apices. At CT, pneumatocoels appear as well-defined parenchymal cystic structures with a thin wall. They may be entirely filled with gas, or an air fluid level may be seen. Contralateral mediastinal shift may be seen with large pneumatocoels. They are associated with contusion in blunt trauma and can rupture to cause pneumothorax. Dillman Jr., ETAL expanding upon the unilateral hyperlucent hemithorax in children. Radiographics. 2011, 31:72341. 2e. Appendix carcinoid tumors are the most common primary tumor of the small bowel and appendix. Gastrointestinal carcinoids account for about 85% of all carcinoid tumors, with the remaining 15% occurring in the lungs and bronchi. These tumors arise from the enterochromaffin cells of Kolchitsky. These express serotonin and other histamine-like substances. The appendix is the most common site of carcinoids, accounting for 30% 45%, the small bowel for 25% 35%, the rectum 10% 15%, the colon 5%, and the stomach 3%. Most tumors are clinically silent but may cause pain, obstruction, weight loss, and, rarely, bowel perforation. In rare cases, 7% of small bowel carcinoids, the hormonal load from the tumor may overwhelm the liver's capacity to metabolize serotonin, causing a carcinoid syndrome, recurrent diarrhea, right-sided endocardial fibroelastosis, wheezing/bronchospasm, and flushing of the face and neck. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011, 82628. 3. B. Inflammatory pseudotumor. Endometriosis B, inflammatory pseudotumor C, malakoplakia D, cystitis glandularis E, eosinophilic cystitis. 4. A 33-year-old man presented with fever and pseudotumor is an interesting entity that has been reported in every organ of the body. At imaging, it usually appears as a solitary exophytic or polypoid bladder mass, which may be ulcerated. On T2, weighted MRI, it is heterogeneous, with a central hyperintense component surrounded by a low signal intensity periphery. On post-contrast images, the periphery enhances, whereas the central region enhances poorly. The central region consists of necrotic tissue and the 329. Periphery comprises fascicles of spindle cells and edema to stroma with myxoid components, vessels and inflammatory cells, hence the name pseudosarcomatous fibromyxoid tumor. This structure may produce the pattern of ring-like enhancement observed on CT and MR images suggestive of the diagnosis, but histologic confirmation is essential. Essential. In young adults, the presence of luminal clot surrounding an enhancing bladder mass may also suggest this diagnosis. MRI shows single or multiple masses. On T2, weighted images, cystitis glandularis shows low signal intensity with a central branching high signal pattern. The hyperintense area shows the most contrast enhancement and corresponds to the vascular stalk. Eosinophilic cystitis nodules are hyperintense to muscle on T1, isointense on T2, weighted images, and enhanced after intravenous contrast administration. Wang Yuchong JJ, ETAL. From the archives of the AFIP, sudden onset back pain. Inflammatory markers were slightly raised. MRI spine showed high signal in the L3/for disc space on T2W and STIR images, with enhancement of the disc extending to the adjacent end plates on post-contrast sequences. What is the diagnosis? A. Metastasis B. Prolapsed intervertebral disc C. Sequestrated disc D. Discitis E. Epidural abscess. Inflammatory and non-neoplastic bladder masses, radiologic pathologic correlation. Radiographics. 2006, 26, 6, 18, 47, 68. 4D, discitis pyogenic spondylitis. Spondylitis most commonly involves the lumbar spine and one spinal segment, which consists of two vertebral bodies and the intervening disc. It typically displays low signal intensity on T1 weighted images, with a loss of definition of the vertebral end plate and of the adjacent vertebral bodies, and high signal intensity on T2 weighted images. In the involved disc space, fluid-like signal intensity is seen on both T1 and T2 images. Following the intravenous administration of gadolinium-based contrast material, disc enhancement patterns from homogeneous to patchy non-confluent to peripheral enhancement may be seen. Infected bone marrow also enhances diffusely after contrast material is administered. Contrast-enhanced fat-suppressed MR images are especially useful in demonstrating this marrow abnormality. MR imaging provides better definition of epidural extension of the inflammatory process and compression of the spinal cord and dural sac than other imaging modalities do. Paravertebral and epidural extension may appear in the form of either a phlegmon or an abscess with mixed signal intensity on both T1 weighted and T2 weighted images. Hong SH, ETAL MR imaging assessment of the spine, infection or an imitation. Radiographics. 2009, 29, 2599 612. 612. 5A, calcium pyrophosphate dihydrate crystal. 305. 5. A 65-year-old woman with progressive increase in knee pain and limited mobility is referred by her GP to have a plain X-ray of the knee. Plain films show bilateral chondrocalcinosis along with some other arthritic features. Which one of the following conditions is the most common cause of chondrocalcinosis? A. Calcium pyrophosphate dihydrate crystal deposition disease. B. Hydroxyapatite crystal deposition disease. C. Primary synovial osteochondromatosis. D. Intraarticular synovial cell sarcoma. E. Chronic renal failure. Crystal deposition disease. Pseudogout calcium pyrophosphate dihydrate CPPD deposition disease is a syndrome caused by the deposition of CPPD crystals in and about the joints of middle-aged or older adults. 3 discrete manifestations of this deposition of CPPD crystals are recognized. 1. Chondrocalcinosis. 2. Typical arthropathy. And 3. The clinical presentation of pain. Any combination of these features may suffice to suggest the diagnosis of pseudogout. Other causes of chondrocalcinosis include the following: hyperparathyroidism, gout, Wilson disease, hemochromatosis, ochronosis, trauma, osteoarthritis, hypothyroidism, hypomagnesemia, acromegaly, oxalosis, and hydroxyapatite deposition disease, HADD. Dannert W. Radiology Review Manual, 7th ed. Six. A 14-year-old boy with family history. History of pulmonary chondroma in his elder brother is investigated with a CT of the chest and abdomen. The CT shows a 3 times 3 cm calcified perihilar lung mass and a large mixed density mass in the left upper quadrant, anterior to the spleen inseparable from the stomach. What other finding S would you expect on the CT? A. Bilateral renal carcinoma. B. Hepatoblastoma. C. Multiple cysts in the lung, kidney, and pancreas. D. Wilms tumor on the right. E. Multiple extraadrenal neuroblastomas. 7. Transverse US image of a fetal thorax with a 4-chamber view of the heart demonstrates homogeneous intermediate echogenicity of the right. 6. E. Multiple extraadrenal neuroblastomas. The question describes the Carney triad, pulmonary chondroma, gastric gist, and multiple extraadrenal neuroblastoma. Cancer predisposition syndrome, CPS, is the term that is generally reserved to describe familial cancers in which a clear mode of inheritance can be established. Individuals may present with one or more key physical features or congenital anomalies, e.g. hemihypertrophy. Patients may have specific tumors that are known to be highly associated with a CPS, e.g. hemangioblastomas in VHL, von Hippel-Lindau syndrome, disease. Some physical features suggesting CPS are cafe au lait spots, NF1, NF2, blooms, angiofibromas, tuberous sclerosis, TS, pits in palms and solace, Gorlin, macrocephaly, Sotos, Cowden, Gorlin, macroglosia, BWS, Beckwith-Wiedemann syndrome, hyperpigmentation, NF1, Fanconi anemia, blooms, spotty skin pigmentation, Carney complex, hemihypertrophy, NF1, BWS, Klippel-Trenaunah syndrome, thumb malformation, Fanconi anemia, aniridia, WAGR, Wilms tumor, aniridia syndrome with genitourinary anomalies, and so on. Tumors associated with CPS include Wilms tumor, WAGR, BWS and several others, hemangioblastoma, VHL, clear cell renal carcinoma, VHL, TS, pheochromocytoma, VHL, MEN2B, NF1, hepatoblastoma, BWS, familial adenomatous polyposis, FAP, adrenocortical and breast carcinoma, Li-Fraumeni syndrome, LFS, optic glioma and neurofibrosarcoma, NF1, retinoblastoma, familial retinoblastoma, gastric cancer and GIST, FAP, NF1, Carney triad, HNPCC, hereditary non-polyposis colorectal cancer or Lynch syndrome, LFS, MEN1, neuroblastoma, NF1, BWS, rhabdomyosarcoma, LFS, NF1, BWS, hereditary retinoblastoma, and so on. Screening tests and pathways have been established for several of these CPSs. These include US abdomen for BWS, LFS, FAP, and VHL, prophylactic thyroidectomy for men 2, and so on. Monsalve J. ETAL imaging of cancer predisposition syndromes in children. Radiographics. 2011, 31, 1 to 6380. 7. B. Normal lung reduces T2 intensity as it matures. At US, the fetal lungs Right lung. The heart is mildly rotated to the right, and there are cystic areas in the left side of the thorax suggesting a diaphragmatic hernia. All of the following are true regarding investigation of congenital lung anomalies, except A. Meconium shows high T1 and low T2 signal on MRI. B. Normal lung reduces in T2 intensity as it matures. C. Secondary pulmonary hypoplasia is more common than primary. D. Interventricular septum determines the cardiac axis. E. Echogenicity of lung advances as gestation advances. Lungs normally appear homogeneous and are slightly more echogenic than the liver. The echogenicity of the lung increases as gestation advances. Advances. The presence of cysts or focal increased echogenicity of the lung parenchyma indicates a mass. The axis of the heart is determined relative to the interventricular septum. At MR imaging, the trachea, bronchi, and lungs demonstrate high T2 signal intensity relative to the chest wall muscles because they contain a significant amount of fluid. As the lungs mature, there is increasing production of alveolar fluid, thereby increasing the T2 signal intensity of lung relative to the liver. Pulmonary hypoplasia can be primary or secondary. Primary pulmonary hypoplasia is less common. The most common intrathoracic cause of secondary pulmonary hypoplasia is congenital diaphragmatic hernia. The herniated liver can be confused with a mass originating in the lung. Color Doppler imaging may be helpful in identifying the portal and hepatic veins. Meconium-filled large bowel is hyperintense on T1, weighted images, and hypointense on T2, weighted images. Therefore, intrathoracic herniation of the large bowel can easily be detected at MR imaging. The most common extrathoracic cause of pulmonary hypoplasia is severe oligohydramnios, secondary to either fetal urogenital anomaly or premature rupture of membranes. By EMDR, ETAL congenital lung abnormalities, embryologic features, prenatal diagnosis, and postnatal radiologic pathologic correlation. Radiographics. 2010, 30, 617 21 38. 8b. Iliopectineal line on radiographs. The iliopectineal, or iliopubic, line represents the border of the anterior column, and the ilioscale line represents the posterior column. Chapter 12. Test paper 6, answers. 331. Fracture involvement of the anterior and posterior columns is characterized by disruption of the iliopectineal line and ilioscale line, respectively. However, disruption of these lines may also be seen with other fracture patterns, such as a transverse fracture. Obturator ring and iliac wing involvement must also be present for classification as a both-column acetabular fracture. Durkee, New Jersey, ETAL classification of common acetabular fractures, radiographic and CT appearances. AJR AMJ Rentgenol. 2006, 187, for 9/15/25. 9a. Systemic lupus erythematosus, SLE, systemic lupus erythematosus, SLE, patients with antiphospholipid antibody, APLB, syndrome present with arterial and veno-occlusive disease, thrombocytopenia, and recurrent vascular thrombosis. Advances. 8. A 42-year-old man who sustained a comminuted acetabular fracture underwent a CT of his pelvis for further characterization and treatment planning. The CT report described it as an anterior column acetabular fracture. Which one of the following anatomic structures must be disrupted on the CT? A. Ilioscale line B, iliopectineal line C, sacroiliac joint D, anterior wall E, posterior wall. 9. A 29-year-old woman has come to the A&E department with 3 months history of shortness of breath after her second miscarriage. She had an episode of pulmonary embolism during her first pregnancy and epilepsy in her teens. Chest radiograph done in the A&E department shows progressive enlargement of cardiac silhouette and left-sided pleural effusion. What is the likely diagnosis? A. Systemic lupus erythematosus, SLE, B. Rheumatoid arthritis, C. Wegener's disease, D. Polyarteritis nodosa, PAN, E. Homocystinuria. Chapter 11. Test paper 6, questions. 306. 10. Abdominal computed tomography, CT, in a 57-year-old patient with nonspecific abdominal pain demonstrates an elongated cystic mass in the expected region of the appendix. The lesion appears to be invaginating into the cecum and demonstrates curvilinear calcification in its wall. What is the most likely diagnosis? A. Lipomatosis of iliacecal valve, B. Carcinoid tumor of the appendix, C. Mucocele of the appendix, D. Epiploic appendigitis, E. Myxoglobulosis. 11. Thromboses and miscarriages. Patients with APLB syndrome can present with recurrent strokes, but Chiari syndrome, dural venous sinus thrombosis, ischemic bowel, and recurrent pulmonary embolism. Exudative pericardial effusions and pericarditis are common. Plural. Effusions are the most common manifestation of SLE in the respiratory system, and are bilateral in approximately 50% of patients. Epileptic seizures are seen in 11% patients with SLE, with association of APLB syndrome and stroke. Lalani Ta, ETAL imaging findings in systemic lupus erythematosus. Radiographics. 2004, 24, for 1069-86. 10. C. Mucocele of the appendix. Mucocele of the appendix is an umbrella term used for the appearance of a cystic mass within the appendix that has varying pathological cause. Mucoceles may be secondary to mucosal hyperplasia, 25%, mucinous cystadenoma, 63%, and mucinous cystadenocarcinoma, 12%. The WHO, Hounsfield unit, value of the cystic lesion is variable from water density to soft tissue density depending on the volume of mucin present within it. A CT scan is good at demonstrating the curvilinear, or punctate rim-like calcification that is present in approximately 50% of cases. Ultrasound may demonstrate a right lower quadrant lesion with either cystic or mixed internal echogenicity depending on the amount of mucin. Rupture of mucoceles may lead to pseudomyxoma peritonia with characteristic findings of multiple thin-walled cystic masses of varying sizes in the abdomen, scalloping of the liver and splenic margins, and a gelatinous ascites. Myxoglobulosis is a rare variant of mucocele with characteristic small, rounded calcific spherules. Dannert W., Radiology Review Manual, 7th ed. 11. Tuberculous spondylitis is diagnosed in a 44-year-old woman with progressive neurological deficit with severe discovertebral destruction and compression of the spinal cord at the T11-12 level on sagittal T2W and Sturmister images. Post-contrast images show a rim-enhancing anterior abscess that does not encase the intercostal arteries. All of the following features are more likely to represent tuberculosis spondylitis compared to pyogenic spondylitis, except A. Subligamentous spread, B. 3 or more vertebral level involvement, C. Skip lesions, D. Homogeneous enhancement of the disc, E. Paraspinal calcification. 12. A CT cystogram is being performed on a 40-year-old man brought to the A&E department after a fall from a roof. Blood is seen at the external urethral meatus on examination. Ed. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2011:877. 11. D. Homogeneous enhancement of the disc. Spinal tuberculosis most commonly involves the thoracic spine, and less often the lumbar spine. It is often difficult to differentiate between tuberculous and pyogenic spondylitis, both clinically and on images. MR imaging is very helpful for differentiating between tuberculous spondylitis and pyogenic spondylitis. A well-defined paraspinal mass with abnormal signal intensity, a thin, smooth abscess wall, subligamentous spread to 3 or more vertebral levels, and multiple vertebral or entire body involvement are findings more suggestive of tuberculous spondylitis than of pyogenic spondylitis. The presence of skip lesions and of a large paraspinal cold abscess is also suggestive of tuberculous spondylitis. However, because they barely penetrate the anterior longitudinal ligament, neither an anterior paraspinal phlegmon or an abscess encasing the intercostal arteries is seen in spinal tuberculosis. MR imaging is less sensitive than radiography or CT for identifying paraspinal calcifications, which are a distinctive imaging feature of spinal tuberculosis. Pyogenic spondylitis most commonly involves the lumbar spine and one spinal segment. Hong S.H. ETAL MR imaging assessment of the spine, infection or an imitation. Radiographics. 2009, 29. The CT scan shows focal thickening of the urinary bladder wall, with no extravasation outside the bladder. Which of the following is the most likely injury sustained? A. Bladder contusion, B. Intraperitoneal bladder rupture, C. Extraperitoneal bladder rupture, D. Combined intraperitoneal and extraperitoneal bladder rupture, E. Subserosal bladder rupture. 13. A 28, year 29, 2599 612. Chapter 12. Test paper 6, answers. 332. 12a. Bladder contusion is the most common bladder injury following trauma. Unlike the other choices, there is no contrast extravasation. The CT scans can show an intramural hematoma, seen as a focal ellipse-shaped thickening of the bladder wall. This may appear as a crescent-shaped filling defect on cystography. Subserosal bladder rupture is seen as an elliptical contrast extravasation adjacent to the bladder on CT. Both intraperitoneal and extraperitoneal bladder rupture can be seen as extravasation outside the bladder. Brantwee, Helm C.A., Fundamentals of Diagnostic Radiology, 3rd ed. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2006:9045. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2011:999. 13. The 28-year-old man with sudden onset of heart murmur and a normal chest radiograph is admitted for progressive shortness of breath on exertion over the recent months. There is a positive family history for heart murmurs and sudden death of a sibling at the age of 30 years. While in the hospital, he developed an acute, severe bout of central chest pain, which prompted an urgent CT of the chest. The CT of the chest shows dissection of an enlarged ascending aorta. What is the diagnosis? A. Homocystinuria, B. Marfan syndrome, C. Ehlers-Danlos syndrome, D. Pseudoxanthoma elasticum, E. Mucopolysaccharidosis. B. Marfan syndrome. Annuloaortic ectasia, a condition characterized by dilated sinuses of Valsalva with effacement of the sinotubular junction, with normal caliber arch, is most commonly associated with Marfan syndrome. Other causes include homocystinuria, Ehlers-Danlos syndrome, and osteogenesis imperfecta. However, annuloaortic ectasia can be idiopathic, although onset and progression is more rapid in Marfan syndrome. Common cardiovascular manifestations include annuloaortic ectasia with or without aortic valve insufficiency, aortic dissection, aortic aneurysm, pulmonary artery dilatation, and mitral valve prolapse, most of which are substantial contributors to mortality. Homocystinuria presents with thromboembolic episodes like stroke. Murmurs related to AR or MR are not commonly associated with the other conditions. Agarwal PP, ETAL multidetector CT of thoracic aortic aneurysms. Radiographics. 2009, 29, 25, 37, 52. 14. The appendix. The clinical picture and CT findings are characteristic for pseudomyxoma peritonia, a process of gradual accumulation of large amounts of gelatinous/mucinous material within the peritoneum. This accumulation of mucin is secondary to a ruptured mucocele of the appendix. Characteristic CT findings include omental caking, thickening of the peritoneum, and mesentery. Mucopolysaccharidosis. 14. A 59-year-old patient is admitted with general lethargy, weight loss, and gradual abdominal distension. Diagnostic workup included an abdominal CT scan, which demonstrated thickening of the peritoneal surfaces and a large, multiloculated denticitis, causing secondary scalloping of the liver edge. What is the most likely location of the primary tumor? A. Stomach, B. Appendix, C. Pancreas, D. Liver, E. Rectum. Chapter 11. Test paper 6, questions. 307. Mesentery, large gelatinous ascites and scallop contour of the liver and slash or splenic borders. The ascites may vary from water density to a very thick soft tissue density, which is dependent on the volume of mucin within the fluid. It is important to always scrutinize the appendix to identify the mucocele once the secondary features are identified. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2011:883. 15. B. Cystitis cystica. 15. A 44-year-old woman with recurrent urinary tract infections is referred for a renal tract ultrasound. This demonstrates normal kidneys and multiple fluid-filled cysts within the bladder wall. Which of the following is the most likely cause? A. Transitional cell carcinoma, B. Cystitis cystica, C. Emphysema 2 cystitis, D. Eosinophilic cystitis, E. Interstitial cystitis. 16. A 22-year cystica and cystitis glandularis are inflammatory processes of the bladder wall with multiple small, round, cyst-like elevations in the submucosa. They are often associated with irritants such as chronic infection, calculi, or bladder outlet obstruction. The hallmark of emphysema 2 cystitis is gas within the bladder wall. The main risk factors are diabetes mellitus and bladder outflow obstruction. Eosinophilic cystitis can present with a nodular bladder wall, but the nodules would be echogenic on ultrasound in comparison with the fluid-filled cysts of cystitis cystica. In any event, all focal bladder abnormalities seen at imaging should be evaluated cystoscopically. In interstitial cystitis, the bladder wall becomes thick and trabeculated. Brantwee, Helm C.A., Fundamentals of Diagnostic Radiology, 3rd ed. Philadelphia, Pa, Lippincott Williams and Wilkins, 2006:900. 22-year-old man presents to the A&E department with a painful swollen ankle following a twisting injury. Plain X-rays showed no fracture, although diffuse soft tissue swelling was evident. The ankle mortise was intact. Incidental note was made of a benign lesion in the mid-shaft of the fibula, which the reporting radiologist described as a fibrous cortical defect. Which one of the following statements regarding this entity is false? A. They are smaller than non-ossifying fibromas. B. Pathological fractures tend to end in non-union. C. Both show dense sclerotic border on CT. D. They commonly affect the metaphysis of long bones. E. They are uncommon in the upper extremity. 17. A 43-year-old man presents to the A&E department with severe headache and is sent for an urgent CT brain, which is normal. MRI shows loss of normal flow void in the basal cisterns, with intense enhancement along the cisterns on post-contrast images. What is the likely diagnosis? A. Subarachnoid hemorrhage. B. Lymphoma. C. TB meningitis. D. Ruptured dermoid cyst. E. Creutzfeldt-Jakob disease, CJD. 16. B. Pathological fractures tend to end in non-union. Benign bone tumors in the fibrous group include benign fibrous cortical defect, FCD, non-ossifying fibroma, NOF, osteofibrous dysplasia, OFD, fibrous dysplasia, FD, and fibroma. Benign fibrous cortical defects and non-ossifying fibromas are the most common tumors in the Chapter 12. Test paper 6, answers. 333. Benign fibrous group. Benign cortical defects and non-ossifying fibromas are eccentric, cortical bone lesions, usually located in the metaphyses of long bones. Non-ossifying fibromas are usually larger than fibrous cortical defects. The most common locations for fibrous cortical defects are the distal femur, proximal tibia, and distal tibia. They occur less commonly in the fibula and are relatively uncommon in the upper extremity. On CT, both benign fibrous cortical defects and non-ossifying fibromas have a dense sclerotic border, and on MRI both are of low signal intensity on T1 weighted and T2 weighted images. Pathologic fractures are more common with the larger non-ossifying fibroma variant. They tend to heal spontaneously. Dave A. ETAL benign bone tumors part I, benign fibrous bone tumors. Contempt Diane Radiol. 2007, 30, 24-6. 17. C. TB meningitis tuberculous meningitis, TBM, is the most common manifestation of CNS tuberculosis across all age groups. The typical radiographic finding is abnormal meningeal enhancement, usually most pronounced in the basal cisterns. These findings are better seen at gadolinium-enhanced MR imaging than at CT. Appearances usually resolve relatively quickly with adequate treatment, however, radiographic resolution is delayed if there are thickened exudates. This appearance is nonspecific and has a wide differential diagnosis that includes meningitis from other infective agents, inflammatory diseases such as rheumatoid arthritis and sarcoidosis, and neoplastic causes, both primary and secondary. The presence of high density within the basal cisterns on non-contrast CT scans is a very specific sign for TBM in children. The most common complication of tuberculous meningitis is communicating hydrocephalus. Ischemic infarcts are also common, being seen in 20%-40% of patients at CT, mostly within the basal ganglia or internal capsule resulting from vascular compression and occlusion of small perforating vessels. Cranial nerve 2, 3, 4 and 7 involvement is reported. Andronikau S. ETAL definitive neuroradiological diagnostic features. CJD. 18. A 6-year-old child is admitted to the emergency department with a head injury. The emergency department consultant demands an urgent CT of the head. Which of the following risk factors would warrant a CT of the head within 1 hour of the injury? A. 2 episodes of vomiting after the head injury. B. Amnesia of events 10 minutes preceding the head injury. C. Fall from a playground climbing frame of 3 meters in height. D. GCS of 13 on initial clinical assessment. E. Abnormal drowsiness. 19. An 8-year-old boy attends the emergency. Features of tuberculous meningitis in children. Pediatric Radiol. 2004, 34, 11, 876, 85. Burrell J. ETAL tuberculosis, a radiologic review. Radiographics. 2007, 27, 512, 55, 73. 18. D. GCS of 13 on initial clinical assessment according to the latest NICE guidelines. For children who have sustained a head injury and have any of the following risk factors, perform a CT head scan within 1 hour of the risk factor being identified. Suspicion of non-accidental injury post-traumatic seizure, but no history of epilepsy on initial emergency department assessment. GCS less than 14 or for children under 1 year, GCS, pediatric, less than 15 at 2 hours after the injury, GCS less than 15 suspected open or depressed skull fracture or tense fontanelle any sign of basal skull fracture, hematympanum, panda eyes, cerebrospinal fluid leakage from the ear or nose, or battle sign, focal neurological deficit for children under 1 year, presence of bruise, swelling or laceration of more than 5 centimeters on the head. For children who have sustained a head injury and have more than one of the following risk factors, and none of those mentioned above, perform a CT head scan within 1 hour of the risk factors being identified. Loss of consciousness lasting more than 5 minutes, witnessed, abnormal drowsiness 3 or more discrete episodes of vomiting. Chapter 12. Test paper 6, answers. 334. Dangerous mechanism of injury, high-speed road traffic accident either as pedestrian, cyclist or vehicle occupant, fall from a height of greater than 3 meters, high-speed injury from a projectile or other object, amnesia, antegrade or retrograde, lasting more than 5 minutes. Head injury, assessment and early management. Clinical guideline, CG 176. Published date, January 2014. https. Emergency department after his bicycle collides with an oncoming car. The ambulance crew have immobilized his cervical spine and report that the patient was complaining of severe neck ache. All of the following risk factors warrant a CT of the cervical spine without obtaining a plain radiograph except A. The patient is already attending the department for a CT of the head. B. Fall from a height of more than 1 meter. C. Loss of sensation in the upper arms. D. GCS of 13 on initial assessment. E. The child needs to be intubated. https://www.nice.org.uk/guidance/CG176 accessed on February 22, 2017. 19. B. Fall from a height of more than 1 meter according to the latest NICE guideline for spinal injury. Perform MRI for children under 16s if there is a strong suspicion of cervical spinal cord injury as indicated by the Canadian C-spine rule and by clinical assessment, or cervical spinal column injury as indicated by clinical assessment, or abnormal neurological signs or symptoms, or both. Consider plain X-rays in children under 16s who do not fulfill the criteria for MRI in recommendation but clinical suspicion remains after clinical assessment. For imaging in children under 16s with head injury and suspected cervical spine injury, follow the recommendations in the NICE guideline on head injury. For children with a head injury, perform a CT cervical spine scan if GCS is less than 13 on initial assessment. The patient has been intubated. Focal peripheral neurological signs. Paresthesia in the upper or lower limbs. A definitive diagnosis is needed urgently, e.g. before surgery. The patient is having CT for head injury or multi-region trauma. There is strong clinical suspicion of injury despite normal X-rays. Plain X-rays are technically difficult or inadequate. Plain X-rays identify a significant bony injury. CT is to be performed within 1 hour of the risk factor being identified. Head injury, assessment and early management. Clinical guideline, CG176, published date. Intubated. 20. A 34-year-old man with history of measles infection showed marked cerebral atrophy on MRI with high signal in the deep white matter bilaterally on T2 and FLAIR images. What is the most likely diagnosis? A. Adrenoleukodystrophy. B. Alexander's disease. Chapter 11. Test paper 6, questions. 308. C. CJDD, progressive multifocal leukoencephalopathy, PML, E. Subacute sclerosing panencephalitis. 21. A 25-year-old man presents with left hip/groin pain after exercise that worsens on internal rotation of the hip. A plain AP radiograph of the pelvis shows an osseous protrusion at the femoral head neck junction, and the measured alpha angle is greater than 55 degrees. Which of the following is the most likely diagnosis? A. Pincer-type femoroacetabular impingement. B. Cam-type femoroacetabular impingement. C. Missed congenital hip dislocation. D. Focal acetabular overcoverage. E. Protrusio acetabuli. 22. Chest radiograph. Date, January 2014. https://www.nice.org.uk/guidance/CG176 accessed on February 22, 2017. Spinal injury, assessment and initial management. NICE guideline, NG41, published date, February 2016. https://www.nice.org.uk/guidance/NG41 accessed on February 22, 2017. 20. E. Subacute sclerosing panencephalitis Creutzfeldt-Jakob disease, CJD, shows high signal intensities in the basal ganglia, putamen, and caudate nucleus, and in the cortex on DW images. The high signal intensities in the basal ganglia are also prevalent on T2 weighted and FLAIR images. The cortical hyperintensities are usually not visualized on T2 weighted and FLAIR images, advantage of DW imaging. Progressive multifocal leukoencephalopathy, PML, is a demyelinating disease of immunocompromised patients caused by human papoviruses. Subacute sclerosing panencephalitis, SSPE, occurs several years after measles infection. SSPE typically starts with mental and behavioral abnormalities, myoclonia, tremor and seizures. Multifocal, hyperintense foci in white matter and the basal ganglia have been reported in PML and SSPE on T2 weighted images. On T2 weighted and FLAIR images, PML and SSPE are associated with white matter lesions, whereas CJD is not. The high signal intensity cortical lesions on DW images may be also a hallmark of CJD. Stadnik TW, ETAL imaging tutorial, differential diagnosis of bright lesions on diffusion weighted MR images. Radiographics. 2003, 23, 1E7. Chapter 12. Test paper 6, answers. 335. 21. B. Cam-type femoroacetabular impingement, FAI, is a major cause of premature osteoarthritis of the hip. It is split radiographically into two main types. Pincer-type impingement is the acetabular cause of FAI and is secondary to either focal or generalized overcoverage of the femoral head by the acetabulum. Cam-type impingement is the femoral cause and is secondary to an asphericity of the femoral head and offset of the femoral head neck junction. Cam impingement is more common in young men and leads to increased alpha angle diagnostic 55 degrees. The osseous bump at the head neck junction may be located laterally, resulting in the pistol grip deformity seen on AP pelvis. Protrusio acetabuli occurs when the femoral head is overlapping the ilioischial line medially, and may be idiopathic or secondary to causes such as rheumatoid arthritis, Paget disease Marfan syndrome, and osteomalacia. 10 Ast M, ETAL femoroacetabular impingement. Radiographic diagnosis. What the radiologist should know. AJR AMJ Röntgenol. 2007, 188:154052. 22. B. Plumage in the pre-chemotherapy. Radiograph of a currently asymptomatic 84-year-old man shows a large well-defined soft tissue density mass in the left apex with a sharp inferior margin. There is underlying rib abnormality, suggesting previous surgery, and sheet-like pleural calcification in the left mid and lower zone. What is the diagnosis? A. Aspergilloma. B. Plumage. C. Pankos tumor. D. Bronchogenic cyst. E. Lymphoma. 23. An adult patient was admitted to hospital with abdominal pain, jaundice, and a palpable epigastric mass. Ultrasound demonstrated isolated dilatation of the common bile duct with otherwise normal appearance of the proximal biliary tree. What is the most likely diagnosis based on the sonographic findings? A. Chuld-Ockel cyst. B. Caroli disease. C. Cholecocele. D. Common bile duct diverticulum. E. Impacted common bile duct calculus. 24. A 40-year-old patient emigrating from pre-chemotherapy era. Surgical management of pulmonary TB included thoracoplasty or plumage, in which an extrapleural space was created between parietal pleura and the chest wall, which was filled with materials such as fat, oil, wax packs, bone or methylmethacrylate, leucite, balls. Appearance on chest radiograph depend on the material used, with associated chest wall deformity, resected ribs or stigma of pulmonary TB like calcified granulomas, lymph nodes or sheets of pleural calcification. Pancreas tumor when large would often be associated with destroyed ribs, and the description does not fit with an aspergilloma, visible air crescent, or bronchogenic cysts, which are homogeneous and mostly located around the carina. Gertier M. Rosette J. Clinical images, thoracic balls. CMAJ. 2011, 183, E1091. 23. A. Chuld-Ockel cyst. The Todani classification system is used to differentiate the cystic processes of the biliary tree into 5 groups. Type 1 cysts, known as Chuld-Ockel cysts, are responsible for 90% of cystic biliary disease. These cysts are further subclassified into IA, dilation of the entire extrahepatic bile duct, IB, focal segmental dilation of the extrahepatic duct, and IC, dilation only affecting the common duct. Patients may present with the triad of vague abdominal pain, jaundice, and a palpable epigastric mass, although this is only reported in 10%-20% of patients. Type 2 cysts are true diverticuli of the bile duct. Type 3, known as a cholecocele, is a focal protrusion of CBD into the duodenum. Type 4 consists of multiple communicating intra- and extrahepatic duct cysts. Type 5, known as Caroli's disease, represents cystic dilatation of intrahepatic ducts. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2011:715. 24. E. Schistosomiasis. This is a classical description of schistosomiasis infection of the blood from an African country is investigated for stone disease because of left-sided renal angle pain. CT of the kidneys, ureters and bladder, KUB, confirms a left renal calculus, but also shows thin curvilinear calcification outlining a normal-sized bladder with involvement of the distal ureters only. Which of the following is the most likely cause? A. Tuberculosis. B. Escherichia coli infection. C. Transitional cell carcinoma. D. Malakoplakia. E. Schistosomiasis. 25. An bladder with curvilinear calcification spreading proximally from the bladder into the distal ureters. The bladder wall can otherwise appear normal but is often thick-walled or nodular. In tuberculosis, the calcification starts in the kidney and can then extend more distally. When involved, the bladder is usually contracted, rather than normal size. Escherichia coli infection is associated with emphysema to cystitis. Bacterial infection can be associated with bladder calculi but not neural calcification. Calcification of transitional cell carcinoma can be linear, curvilinear or stippled. However, a mass or wall thickening would be expected and 97% of cases occur in over 45-year-olds. Malakoplakia is a rare condition and calcification in affected patients is uncommon. Brantwe, Helms C.A., Fundamentals of Diagnostic Radiology, 3rd ed. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2006:901. Davies S.G., ETAL Aids to Radiological Differential Diagnosis, 5th ed. Philadelphia, Pa, Saunders Elsevier. An asymptomatic military recruit showed a well-defined 2 times 2 cm solitary pulmonary nodule in the right lower zone on a plain chest radiograph. On close inspection, the nodule showed faint calcification. CT performed for further characterization showed areas of fat density on pixelometry. What is the diagnosis? A. Tuberculoma. B. Aspergilloma. C. Hamartoma. Chapter 11. Test paper 6, questions. 309. D. Carcinoid. E. Hemangioma. 26. You are performing an abdominal ultrasound. Elsevier 2009:227. Chapter 12. Test paper 6, answers. 336. 25. C. Hamartoma. Hamartoma is a benign neoplasm composed of mesenchymal tissues such as cartilage, fat, connective tissue, smooth muscle, and calcification. Hamartoma are common benign tumors. Typical CT findings consist of a well-defined, smooth, round or lobulated nodule or mass with fat density in nearly 2/3 of cases, and popcorn-like calcification or central calcification in a quarter. Furiac, ETAL lung CT, Part 1, mimickers of lung cancer spectrum of CT findings with pathologic correlation. AJR AMJ Rentgenol. 2012, 199:4. 26. E. Ultrasound scan on a woman who has been complaining of chronic abdominal pain. There is a large 20 cm multiloculated, ovoid anechoic mass in the right lobe of liver. The internal septations are well visualized and hyperechoic. Further investigation with CT demonstrates enhancement of its thick wall and internal septations. What is the most likely diagnosis? A. Simple hepatic cyst. B. Chuld-Ockel cyst. C. Echinococcal cyst. D. Caroli disease. E. Biliary cyst adenoma. 27. An intravenous urogram is performed on a 70-year-old diabetic for recurrent E. coli urinary tract infections. This demonstrates multiple small, smooth, plaque-like mural defects of the bladder and distal ureteric. Biliary cyst adenoma. Biliary cyst adenomas are benign neoplasms originating in bile ducts, most commonly seen within the right lobe of liver. They rarely affect the extrahepatic biliary system. Women are affected more than men and typically present with chronic, vague abdominal pain. Biliary cyst adenomas can reach up to 35 cm in size, and are usually demonstrated as large multiloculated anechoic masses on ultrasound. A CT scan typically demonstrates a water density mass that shows enhancement of its walls and septations following administration of contrast, differentiating these from simple cysts. An echinococcal cyst, hydatid cyst, is a parasitic infection causing cystic transformation in the liver. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2011:705. 27. Ureteric walls. Which of the following is the most likely cause? A. Emphysema cystitis. B. Malakoplakia. C. Leukoplakia. D. Hemorrhagic cystitis. E. Bladder outflow obstruction. 28. A 45-year-old woman presents with right hip pain. An AP radiograph of the hip shows a large lucent lesion with stipple calcification and a wide destructive appearing zone of transition. Which of the following is the most likely diagnosis? A. Osteomyelitis. B. Osteosarcoma. C. Chondrosarcoma. D. Fibrous dysplasia. E. Chondromyxoid fibroma. 29. A 37-year-old woman with progressive worsening of headache had a facial 27. B. Malakoplakia. Malakoplakia is a rare chronic inflammatory disease primarily affecting the bladder, with decreasing incidence with increasing proximity to the kidney. Small smooth papules, nodules or plaque-like mural defects of the affected urinary tract are characteristic. Malakoplakia can be associated with immunosuppression, diabetes mellitus, renal transplants, or long-term corticosteroid use. Leukoplakia is characterized by soft tissue flakes that can be passed in the urine during micturition. Hemorrhagic cystitis and emphysema cystitis can occur with E. coli infections, but are associated with intraluminal blood clots and gas deposits, respectively. Bladder outflow obstruction results in a thick-walled bladder with trabeculations. Brantwe, Helm C.A., Fundamentals of Diagnostic Radiology, 3rd ed. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2006:901. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2011:952. 28. C. Chondrosarcoma. The radiographic description is aggressive, and the stipple calcification is suggestive of a chondroid matrix. The most likely diagnosis is therefore a chondrosarcoma. These may be primary or develop from an enchondroma or osteochondroma. Although chondromyxoid fibroma would be a possibility in this age group, it is an exceedingly rare benign chondral lesion that would normally have well-defined, thickened sclerotic margins. Chondrosarcomas are quite common tumors that may have relatively benign radiographic appearances. They are normally metaphyseal, located centrally within the skeleton, and may exhibit endostele scalloping. The diagnosis should also be considered in patients with increased pain or growth in centrally located enchondromas or osteochondromas. Surgical resection is the treatment of choice, and the 5-year survival rate is approximately 75%. Monester B.J., ETAL. The requisites, MSK. MSK Imaging, 3rd ed. Philadelphia, Pa, Mosby, 2007:456-9. 29. C. Sarcoidosis. Causes of optic canal enlargement, more than 6.5 mm in diameter. Common causes: glioma of the optic nerve, meningioma of the optic nerve sheath, metastasis, neurofibromatosis with or without optic neurofibroma or glioma. Chapter 12. Test Paper 6. Answers. 337. Uncommon causes. Aneurysm of the ophthalmic artery or cavernous portion of internal carotid artery, arteriovenous. Facial series done following an injury to the face when she fell while skating. PA view of the skull and OM view did not show any fractures. Incidental note was made of enlarged optic canals. All of the following are associated with this, except A. NF1B, optic glioma. C. Sarcoidosis. D. Sphenoid mucocele. E. Ophthalmic artery aneurysm. 30. A 1-year. Malformation with ophthalmic artery involvement, carcinoma of ethmoid. Ethmoid or sphenoid sinus granuloma, e.g. tuberculosis, sarcoidosis, increased intracranial pressure mucocele of sphenoid sinus mucopolysaccharidosis, especially Hurler syndrome, pituitary adenoma, or craniopharyngioma extending anteriorly, pseudotumor of orbit, retinoblastoma with intracranial extension. Reader millimeter gamut B. 13, optic canal enlargement. In, Reader and Felson's gamuts in radiology. Head and neck, Reader MM, ed., New York, Springer Verlag, 2003:10910. 30. C. AP radiograph of the cervical spine. The standard child protection skeletal survey for suspected non-accidental injury includes the following. Skull AP, lateral and Towns view, the latter if clinically indicated. 1-year-old child is admitted with seizures and found to have bilateral subdural hematomas. There is concern regarding non-accidental injury, and a full skeletal survey is requested. According to the Royal College of Radiologists guidelines, which radiograph S would not be routinely included in a full skeletal survey. A. PA radiograph of the right hand. B. AP radiograph of the left tibia and fibula. C. AP radiograph of the cervical spine. D. Lateral radiograph of the lumbar spine. E. Right oblique radiograph of the chest. 31. A term neonate is found in respiratory distress with shortness of breath and tachypnoea on day 1 of life. An urgent chest radiograph demonstrates a right-sided pneumothorax. Indicated. Skull X-rays should be taken even if a CT scan has been or will be performed. Chest AP including the clavicles. 2 oblique views to show ribs, left and right oblique. Abdomen AP including the pelvis and hips. Spine lateral, may require separate exposures of the cervical, thoracic and thoracolumbar regions. AP views of the cervical spine are rarely diagnostic at this age, and should only be performed at the discretion of the radiologist. Limbs AP of both upper arms, AP of both forearms, AP of both femurs, AP of both lower legs, PA of hands, DP of feet. Where an abnormality is suspected, these views should be supplemented by the following: lateral views of any suspected shaft fracture AP, and lateral cone views when a fracture is suspected. Standards for radiological investigations of suspected pneumothorax. Chapter 11. Test paper 6, questions. 310. There is no history of any antenatal complications. What is the most likely underlying cause? A. Respiratory distress syndrome, pulmonary surfactant deficiency. B. Group B streptococcus infection. C. Congenital pulmonary airway malformation, CPAM. D. Meconium aspiration. E. Congenital diaphragmatic hernia, CDH. 32. A 58-year-old man who worked in the mines for several years presented with progressive shortness of breath on exertion. Extensive interstitial thickening and small nodules bilaterally with large masses of consolidation in the upper lobes were noted on the most recent chest radiograph. Comparison with previous films suggested central migration of the consolidation like upper lobar masses. What is the diagnosis? A. Pneumoconiosis with progressive massive fibrosis. B. End-stage sarcoidosis. C. End-stage Langerhans cell histiocytosis, LCH. D. Cryptogenic fibrosing alveoli. Suspected non-accidental injury, the Royal College of Radiologists, March 2008. Ref. BFCR 081, available at https://www.rcr.ac.uk/system/files/publication field_score/rcpch_file/rcr_final_0.pdf. 31. D. Meconium aspiration is the most common cause of neonatal respiratory distress in full-term or post-mature infants. Hyaline membrane disease is the most common cause in premature infants. Chapter 12. Test paper 6, answers. 338. Chest X-ray shows the following: bilateral diffuse grossly patchy opacities, atelectasis and consolidation. Unlike hyaline membrane disease, air bronchogram is not a typical feature. Hyperinflation with areas of emphysema, air trapping. Spontaneous pneumothorax and pneumomediastinum, 25%, requiring no therapy. Small pleural effusions, 20%. Rapid clearing, usually within 48 hours. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011. 32. A. Pneumoconiosis with progressive massive fibrosis on chest radiographs, large opacities, progressive massive fibrosis, may be seen in complicated co-worker pneumoconiosis as in complicated silicosis. The large opacities result from nodule coalescence and are observed commonly in the middle lung zone or peripheral one-third of the lung on axial chest images, and in the upper lung zone on longitudinal images. The large opacities gradually migrate towards the hilum, leaving emphysema 2 lung tissue between the fibrotic tissue and the pleural surface. Chong S. et al. Pneumoconiosis, comparison of imaging and pathologic findings. Radiographics. 2006, 26, 159-77. 33. D. Miritzi syndrome, the sonographic findings of an impacted gallstone within the neck of bladder cause alveolitis E, old TB. 33. A patient is admitted to hospital with progressively worsening jaundice and raised bilirubin levels. Ultrasound of the abdomen demonstrates a large hyperechoic focus casting a shadow within the neck of the gallbladder, causing secondary dilation of the common hepatic and intrahepatic bile ducts proximally. The distal common bile duct, CBD, was normal. What is the most likely diagnosis? A. Caroli disease. B. Choleticocele. C. Caroli syndrome. D. Miritzi syndrome. E. Cholangiocarcinoma. 34. A 30-year-old man is admitted with lower abdominal pain following a road traffic accident in which he was an unrestrained passenger. Blood is seen in his urine, and a bladder injury is suspected. Regarding extraperitoneal bladder rupture, which of the following is incorrect? A. It is more common than intraperitoneal. Causing proximal biliary dilatation are diagnostic for Miritzi syndrome. Miritzi syndrome is caused by impaction of a large gallstone in the cystic duct remnant, or gallbladder neck. The impacted stone causes external compression of the CBD, resulting in proximal dilation of the biliary tree. A choleticocele is cystic dilatation of the CBD within the lumen of the duodenum. Caroli disease is a congenital disorder characterized by saccular dilatations of intrahepatic ducts. Caroli disease, in association with congenital hepatic fibrosis, polycystic kidney disease, and others, is known as Caroli syndrome. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011:747. 34. E. The bladder dome is the most common site of injury. Extraperitoneal bladder rupture accounts for 80% of bladder ruptures. A flame-shaped extravasation of contrast is a classic finding, and can be seen to extend into the perivesical fat, and into the retropubic space of retzius, anterior abdominal wall, upper thigh or scrotum. The most common site of injury is close to the anterolateral aspect of the bladder base. It is usually caused by puncture from pelvic fractures. Brantwe, Helm C.A., Fundamentals of Diagnostic Radiology, 3rd ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2006:904. Danert W., Radiology Review Manual, 7th ed. Philadelphia, Pa, Lippincott Williams and Wilkins, 2011:999. Intraperitoneal rupture. B. A flame-shaped extravasation of contrast can often be seen. C. It is usually caused by puncture from a pelvic fracture. D. Contrast most commonly extravasates into the retropubic space of Retzius. E. The bladder dome is the most common site of injury. $999. Injury. 35. A 4-year-old child presents with short stature and failure to grow. Plain radiographs reveal multiple abnormalities, including generalized increased density of long bones with thickened cortices, widened cranial sutures, Wormian bones, a hypoplastic mandible and shortened pointed distal phalanges. Which of the following is the most likely diagnosis? A. Pycnodycystosis. B. Osteopetrosis. C. Cleidocranial dysostosis. D. Osteosclerosis. E. Kinky hair syndrome. 35. A. Pycnodycystosis. Pycnodycystosis is a congenital abnormality that should be considered in the differential diagnosis of osteosclerosis. The patients are typically short, have hypoplastic mandibles, widened cranial sutures, Wormian bones, brachycephaly, clavicular dysplasia, thick skull base, and hypoplasia, or non-nematization of the paranasal sinuses. The distinguishing feature is acroosteolysis with sclerosis. The distal phalanges appear as if they have been put in a pencil sharpener. They are pointed and dense. Brantwe, Helm C.A., Fundamentals of Diagnostic Radiology, 3rd ed. Syndrome. 36. A man with nasopharyngeal squamous cell carcinoma undergoes MRI staging. A pathological node is seen lateral to the IJV. It lies below the hyoid bone, but above the vocal cords. At which level is this likely to be located? A. IB 2. Chapter 11. Test paper 6, questions. 311. C. 3D, 4E, V. 37. CT. 36. C. 3 clinical classification of neck nodes level I, above hyoid bone level IA, previously called submental nodes level IB, previously called submandibular nodes level 2, from skull base to level of lower body of hyoid bone posterior to back of submandibular gland anterior to back of sternocleidomastoid muscle level IIA, anterior, lateral, medial or posterior to internal jugular vein inseparable from internal jugular vein, if posterior to vein, previously classified as upper. Internal jugular nodes level IIB, posterior to internal jugular vein, with fat plane separating nodes and vein previously classified as upper spinal accessory nodes level 3, from level of lower body of hyoid bone to level of lower cricoid cartilage arch anterior to back of sternocleidomastoid muscle, previously known as midjugular nodes. Level 4, from level of lower cricoid cartilage arch to level of clavicle. Level V, posterior to back of sternocleidomastoid muscle from skull base to level of lower cricoid arch. Level 6, between carotid arteries from level of lower body of hyoid bone to level superior to top of manubrium. Level 7, between carotid arteries below level of top of manubrium. Silverman PM, lymph node imaging, multi-detector CT, MDCT. Cancer image. CT of the chest in a 68-year-old man who worked for 20 years in a coal mine, showed an ill-defined 3 cm spiculated nodule in the apical segment of the lower lobe of the left lung. The lesion was avid on PET and showed high signal on axial T2W MRI thorax. All of the following are true regarding lung cancer and progressive massive fibrosis except A. T2W is useful in differentiating lung cancer from PMF. B. PET-CT is useful in differentiating lung cancer from PMF. C. PMF shows low signal compared to muscle on T1W MRI. D. PMF commonly shows peripheral enhancement on contrast MRI. E. Histopathologic analysis should still be performed for diagnosis. Level 7, between carotid arteries below level of top of manubrium. Silverman PM, lymph node imaging, multi-detector CT, MDCT. Cancer imaging. 2005, 5, S5767. 37, B, PET CT is useful in differentiating lung cancer from PMF. PMF. It is clinically and radiologically important to differentiate progressive massive fibrosis from lung cancer. MRI is a preferable option because lung cancer appears as high-signal lesion on T2, weighted images, whereas progressive massive fibrosis appears as a low-signal abnormality when compared with the signal of muscle on both T1, weighted and T2, weighted images. On post-contrast MR, progressive massive fibrosis appears peripherally enhanced more frequently than not. Histopathologic analysis should still be performed for diagnosis. PET may show intensive uptake of FDG in the fibrotic mass in progressive massive fibrosis, hence differentiation from cancer may be difficult. Chong S. ETAL pneumoconiosis. Diagnosis. 38. A patient is admitted to hospital with jaundice and recent weight loss. Abdominal ultrasound demonstrates marked dilation of the intrahepatic ducts, extending to the liver surface. Note is also made of an isoechoic mass at the porta hepatis. Which of the following is the most likely diagnosis? A. Primary sclerosing cholangitis. B. Klatskin tumor. C. Miritzi syndrome. D. Choldocal cyst. E. Caroli disease. 39. A 17-year-old girl is admitted following a road traffic accident where she was a restrained passenger. She has low-volume hematuria following catheterization. Pre- and post-intravenous. 4. Contrast CT. Comparison of imaging and pathologic findings. Radiographics. 2006, 26, 159-77. 38. B. Klatskin tumor. Klatskin tumors are cholangiocarcinomas that involve the confluence of hepatic ducts and account for up to 70% of cholangiocarcinomas. Dilation of the intrahepatic ducts is the most frequent abnormal finding on ultrasound. Lobar atrophy may be very subtle on ultrasound, but may be identified by secondary findings such as extension of dilated ducts to the liver surface and lobar ductal crowding. The tumor itself may be very difficult to identify on ultrasound, but may present as an isoechoic or hyperechoic mass. Primary sclerosing cholangitis is a fibrotic process that affects the biliary tree causing multifocal strictures and may lead to biliary cirrhosis. Miritzi syndrome is dilation of the proximal common bile duct and intrahepatic duct secondary to external compression of a large gallstone impacted in the cystic duct/gallbladder neck. Sainani NI, ETAL cholangiocarcinoma, current and novel imaging techniques. CT is performed after administering contrast via her urinary catheter. The pre-contrast CT shows contrast within the peritoneal cavity around loops of bowel, and there is irregularity of the bladder wall at the dome of the bladder. No contrast blushes are seen on the arterial phase CT. Which of the following is the most likely injury? A. Extraperitoneal bladder. Bladder rupture. B. Intraperitoneal bladder rupture. C. Subserosal bladder rupture. D. Iliac artery injury with hemorrhage. E. Pelvic hematuria from occult fracture. Radiographics. 2008, 28:12-63-87. 39. The intraperitoneal bladder rupture. Intraperitoneal bladder rupture occurs in around 20% of bladder ruptures. It can be caused by a sudden increase in intravesical pressure owing to blunt trauma, and usually causes rupture to the bladder dome. Contrast. Contrast can be seen in the peritoneal cavity, often outlining loops of bowel and. Chapter 12. Test paper 6, answers. 340. Extending up the parcolic gutters. Extraperitoneal bladder rupture is more common, and is usually caused by puncture from pelvic fractures. Contrast can be seen in the retroperitoneal space, anterior abdominal wall, upper thighs or even the scrotum. It is important to distinguish between intraperitoneal and extraperitoneal rupture. Intraperitoneal rupture requires surgical repair, whereas extraperitoneal rupture is managed conservatively. Contrast outside the bladder would not be seen on the pre-for contrast CT in cases of arterial damage or pelvic hematoma. Brantwe, Helms C.A., Fundamentals of Diagnostic Radiology, 3rd ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2006:904. 40. A. Bone metastasis. The ivory vertebra sign, as described. 40. A 65-year-old man presents with severe upper thoracic back pain, of insidious onset, with little relief from analgesia. Lateral radiographs of his thoracic spine reveals uniformly increased density within the T7 and T9 vertebral bodies, with retention of the vertebral body size and contour. Which of the following is the most likely cause for this finding? A. Bone metastasis. B. Osteoid osteoma. C. Tuberous. Tuberous sclerosis D, osteopetrosis E, fluorosis. 41. Described in this case, refers to a diffuse and homogeneous increase in the density of a vertebral body, which retains its size and contours. It can occur in both adults and children, but is more common in the former. In adults, ivory vertebra has been associated most commonly with fractures, compression or healing, hemangiomas, lymphoma, myelosclerosis, with metastatic disease, especially prostate, breast and carcinoid, chronic sclerosing osteomyelitis, Paget disease and renal osteodystrophy. An ivory vertebra at one or more vertebral levels in an elderly man is most compatible with a diagnosis of metastatic disease, commonly as the result of prostate carcinoma. The other options are all much less common causes of ivory vertebrae. Graham T. 41. A 40-year-old man was punched in the face during an altercation. Clinical examination showed left facial swelling with left-sided ophthalmoplegia and diplopia. X-rays showed a left maxillary fracture. What is the likely cause of the patient's symptoms? A. Superior orbital fissure syndrome. B. Cavernous sinus thrombosis. Chapter 11. Test paper 6. Questions. 312. C. Cortico-cavernous fistula. D. Post-traumatic ophthalmoplegia. E. Cerebral venous sinus thrombosis. T.S. The ivory vertebra sign. Radiology. 2005, 235:614-15. Reader MM, ed., ETAL Reader and Felson's Gamuts in Radiology, Comprehensive Lists of Röntgen Differential Diagnosis, 4th ed. New York, Springer Verlag, 2003. 41. A. Superior orbital fissure syndrome. Because the upper transverse maxillary buttress forms the orbital floor, fractures of this buttress may cause various orbital complications, including inferior rectus muscle tears, globe rupture or impingement, optic nerve injury, and orbital hematoma. Superior orbital fissure syndrome is caused by extension of the fracture through the superior orbital fissure, with resultant injury to cranial nerve 3, 4, V1, the ophthalmic branch of the trigeminal nerve, and 6 as they traverse the fissure into the orbit, thus causing ophthalmoplegia or diplopia, extraocular muscle paralysis, and ptosis, paralysis of the levator palpebris superioris, which is supplied by cranial nerve 3. Additional injury to the optic nerve, cranial nerve 2, at the orbital apex results in orbital apex syndrome, with unilocular visual loss added to the list of signs and symptoms. Orbital apex syndrome is a surgical emergency because prompt intervention is necessary to prevent permanent blindness. Weingar B.A., ETAL Spectrum of Critical Imaging Findings in Complex Facial Skeletal Trauma. Radiographics. 2013, 33:319. 42. A. Hypothyroidism. Causes of delayed bone age include the following. Constitutional, familial and IUGR metabolic, hypothyroidism, hypopituitarism, hypogonadism, Turner syndrome, Cushing disease/steroid therapy, diabetes mellitus, rickets and malnutrition, systemic disease. Disease. Thrombosis. 42. While reporting a plain radiograph of a 10-year-old girl patient's left hand, you notice that her bone age is delayed. There is no indication of the patient's underlying condition on the request form. The bones of the hand are otherwise unremarkable. Which of the following conditions may offer a possible explanation? A. Hypothyroidism. B. Achondroplasia. C. Hemophilia. D. Cushing syndrome. E. Precocious puberty. 43. A. Disease, congenital heart disease, renal disease, celiac disease, Crohn's disease, ulcerative colitis and anemia syndromes, trisomies, Noonan disease, Cornelia de Lange, cleidocranial dysplasia, Lesch-Nyhan disease, metatrophic dwarfism. Of these, in the absence of any other history or radiological abnormality, hypothyroidism is more likely until proven otherwise. Precocious puberty results in advanced bone age. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2011. Chapter 12. Test paper 6, answers. 341. 43. B. Few varying sized nodules, some with cavitation. Wegener's granulomatosis, currently called granulomatosis with polyangiitis, is a probable autoimmune. A 42-year-old man with cough and hemoptysis, swelling of ankles and hand, raised urea, and creatinine on recent blood biochemical profile, presented to the A&E department with bloody nasal discharge. A chest radiograph was performed. What do you expect the chest radiograph to show given the clinical scenario? A. Miliary nodules. B. Few varying sized nodules, some with cavitation. C. Carry hilar infiltrates in a batwing pattern. D. Bilateral upper lobe fibrosis. E. Tramline and gloved finger opacities. Autoimmune disease characterized by systemic necrotizing granulomatous destructive angiitis, with a classic triad of respiratory tract inflammation, systemic small vessel vasculitis, and necrotizing glomerulonephritis. Sinus disease classically includes destructive sinusitis, nasal septal ulceration, septal perforation, and saddle nose deformity. Chest radiograph shows interstitial fibrosis at the bases, which is usually asymptomatic. Multiple pulmonary nodules with cavitation are the most common and characteristic manifestation. Plural. Effusions and mediastinal nodal enlargement are seen. There are multiple causes of miliary nodules, described as innumerable small 1-4 mm lung nodules, described in miliary tuberculosis, fungal infection, metastasis, thyroid, renal, breast, melanoma, pancreas, trophoblastic tumor, sarcoidosis, pneumoconiosis, pulmonary hemosiderosis, varicella infection, hypersensitive pneumonitis, histiocytosis, etc. Bilateral upper lobe fibrosis are classically described in TB, ankylosing spondylitis, sarcoidosis, silicosis, radiation, and histiocytosis. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott, Williams and Wilkins, 2011:551-2. 44 and 87-year-old female patient from a nursing home presents with a history of severe abdominal pain and diarrhea. She has a past medical history of transient ischemic attacks and 2 non-ST elevation myocardial infarctions. Blood results show an elevated lactate level and raised white cell count. CT report states that the most likely cause is ischemic colitis. What is the most likely CT finding? A. Thick-walled cecum with distended appendix. B. Dilated loop of bowel in the left iliac fossa with spiraling vessel. C. Thick-walled edema. 2 loops of bowel with branching lucencies peripherally in liver. D. Thick-walled edema. 2 colon with ascites. E. Dilated small bowel loops with branching linear lucency at the porta hepatis. 44. C. Thick-walled edema. 2 loops of bowel with branching lucencies peripherally in the liver. The patient in this scenario has a history of atherosclerosis with end organ damage. This would make them at risk of developing ischemic colitis. The area of bowel affected in this question is a watershed area and is most susceptible to ischemic colitis. The other plain film findings described in this question include intramural gas and portal venous gas. These are very worrying signs and usually imply a poor outcome. Sigmoid volvulus would cause a coffee bean sign on plain film. The findings are also not suggestive of cecal volvulus or small bowel obstruction. Necrotizing enterocoltis would cause intramural and portal venous gas, however, this is a condition of neonates. Dilated small bowel with gas at the porta hepatis is classic description of gallstone ileus, with gas being in the biliary tree. Pair BL, pneumatoses intestinalis. Intestinalis, a review. Radiology. 1998, 207:1319. Hepatis. 45, a 60-year-old male smoker attends for a CT scan following an ultrasound scan that showed unilateral hydronephrosis. The scan shows a lobulated irregular bladder wall mass that enhances in the portal venous phase to a greater extent than the bladder wall. Which of the following is the likely diagnosis? A. Squamous cell carcinoma. B. Adenocarcinoma. C. Transitional cell carcinoma. D. Leiomyoma. E. Blood clot. 46, a 40-year-old man had a cardiac CT and MRI to evaluate suspected cardiomyopathy. This revealed a well-defined incidental lesion within the T10 vertebral body, with 45, C. Transitional cell carcinoma. Transitional cell carcinoma of the bladder is the most common urinary tract malignancy in the UK and appears as a lobulated, irregular bladder wall thickening that enhances more greatly than the normal bladder wall. If hydronephrosis is present, this suggests muscle-invasive disease. Squamous cell carcinoma can look like this but accounts for only 4% of all bladder malignancies, and is therefore less likely unless there are specific risk factors such as schistosomiasis infection, chronic cystitis, bladder calculi, or long-term catheterization. Adenocarcinoma is rare and associated with urachal remnants or bladder exstrophy. Leiomyomas appears as smooth bladder wall masses. Blood clots do not enhance, and are often seen to change in size and position on sequential scans. Brantwe, Helm C.A. Coarse vertical trabeculae on CT, and high signal on both T1 and T2 sequences on MRI. The lesion enhanced with contrast on both modalities. What is the most likely diagnosis? A. Plasmacytoma. B. Osteosarcoma. Chapter 11. Test paper 6, questions. 313. C. Osteopathias striata. D. Enostosis. E. Hemangioma. C.A. Fundamentals of Diagnostic Radiology, 3rd ed. Philadelphia, Pa, Lippincott, Williams and Wilkins, 2006:903. 46. E. Hemangioma. Vertebral hemangiomas are present in 5%, 11% of all autopsies, and are multiple in 1/3 of these cases. Lesions commonly occur in the vertebral bodies of the lower thoracic and lumbar spine, and radiographic appearances are those of coarse vertical trabeculations, giving a corduroy or honeycomb appearance. A CT scan may also demonstrate small punctuate areas of sclerosis, giving a polka dot appearance. On MRI, the lesions are of a mottled pattern with a characteristic low to high signal on T1, weighted sequences, and high signal on T2, weighted sequences in proportion to the amount of adipose tissue. The lesions enhance strongly on both CT and MRI because of hypervascularity. Dannert W., Radiology Review. Hemangioma. 47, a 30-year-old woman presents with a painless neck mass. MRI confirms that this is a thin-walled cyst lying just anterior to the sternocleidomastoid. There is a tract from the bifurcation of the common carotid artery. What is the diagnosis? A. Lymphangioma. B. Thyroglossal duct cyst. C. First branchial cleft cyst. D. Carotid body tumor. E. Second branchial cleft cyst. 48. A neonate presents with an imperforate anus. 47. E. Second branchial cleft cyst. The vast majority, 95%, of branchial cleft anomalies arise from the second cleft. At least 3/4 of these anomalies are cysts, which typically occur between 10 and 40 years of age, in contrast to fistulas or sinuses, which manifest most commonly during the first decade of life. No gender predilection has been reported. These cysts usually appear as painless, fluctuant masses in the lateral portion of the neck adjacent to the anteromedial border of the sternocleidomastoid muscle at the mandibular angle. The mass enlarges slowly over time and may become painful and tender if secondarily infected. At US, a second branchial cleft cyst is seen as a sharply marginate, round to ovoid, centrally anechoic mass with a thin peripheral wall that displaces the surrounding soft tissues. The mass is compressible and shows distinct acoustic enhancement. Occasionally, fine, indistinct internal echoes representing debris may be seen. The classic location of these cysts, at either CT or MR imaging, is at the anteromedial border of the sternocleidomastoid muscle, lateral to the carotid space, and at the posterior margin of the submandibular gland. The cyst typically displaces the sternocleidomastoid muscle posteriorly or posterolaterally, pushes the vessels of the carotid space medially or posteromedial, and displaces the submandibular gland anteriorly. It may also be seen more medially within the parapharyngeal space, after extending through the stylomandibular tunnel and middle constrictor muscle. MR imaging better depicts the deep tissue extent of a second branchial cleft cyst, which allows accurate preoperative planning. The cyst fluid varies from hypointense to slightly hyperintense relative to muscle on T1, weighted images, and is usually hyperintense on T2, weighted images. Mural thickness and enhancement vary, depending on the presence and severity of any associated inflammatory process. Occasionally, a beak sign may be seen on axial CT or Mr. images. This sign represents a curved rim of tissue or beak pointing medially between the internal and external carotid arteries. It is considered a pathognomonic imaging feature of a second branchial cleft cyst. Kolar KK, ETAL congenital cystic masses of the neck, radiologic path. Anus and a praesacral mass. MRI of the abdomen demonstrates an enhancing lesion with fatty components and T2 asterisk susceptibility artifacts. What other imaging finding would you expect? A. Syrinx within the spinal canal. B. Anterior beaking of the vertebral bodies. C. Sacrococcygeal bony defect. D. Developmental dysplasia of the hips. E. Multiple renal cysts. Pathologic correlation. Radiographics. 1999, 19:12146. 48. C. Sacrococcygeal bony defect. Anterior sacromeningocele may occur as part of the Kerr-Reno triad, also known as the ASP triad, anorectal malformation, sacrococcygeal osseous defect and praesacral mass, a rare syndrome characterized by autosomal dominant genetic inheritance in more than 50% of cases. The praesacral mass in those affected may be a teratoma, anterior sacromeningocele, dermoid cyst, hamartoma, or enteric duplication cyst, or more than one of these types of masses may be present. Cocoa glue M, fresh DP. P. Cysts. 49. A 17-year-old boy presents with an enlarging swelling in the midline at the level of the hyoid bone. The GP suspects a thyroglossal cyst and sends him for an ultrasound. Which of the following appearances is consistent with a thyroglossal cyst? A. Hyperechoic mass in the midline. B. Hyperechoic mass to the left of the midline. C. Anechoic mass in the midline. D. Hyperechoic mass with coarse internal echoes. E. Hypoechoic mass to the left of midline. Pediatric praesacral masses. Radiographics. 2006, 26, 383357. 49. C. Anechoic mass in the midline. On all radiologic images, a thyroglossal duct cyst manifests as a cyst-like mass either in the midline of the anterior neck at the level of the hyoid bone or within the strap muscles just off the midline. At US, the finding of an anechoic mass with a thin outer wall in this characteristic location easily establishes the diagnosis of a thyroglossal duct cyst. However, this classic appearance is seen in less than half of 42% of cases. More commonly, these cysts manifest as hypoechoic masses, often with increased through transmission. They may be either homogeneous or heterogeneous in appearance with variable degrees of fine to coarse internal echoes. There is no correlation between the sonographic appearance and pathologic evidence of infection and inflammation. Heterogeneity seen in thyroglossal duct cysts on sonograms is more likely due to the proteinaceous content of the fluid secreted from the cyst wall rather than to infection. Preoperative sonographic visualization. Chapter 12. Test paper 6, answers. 343. Of normal thyroid tissue is sufficient to exclude a diagnosis of ectopic thyroid tissue and obviates routine thyroid scintigraphy. Kolar KK, ETAL congenital cystic masses of the neck, radiologic pathologic correlation. Radiographics. 1999, 19:12146. 50. 50. A 69-year-old woman presented to her GP with 1 month's history of headache and progressive swelling of both hands and face, and an 8 months history of progressive weight loss. Chest radiograph showed widening of the mediastinum and a large mass in the right upper lobe with a midline trachea. What do you expect the CT chest to show? A. Cavitating lung primary in RUL without mediastinal nodes. B. Right pancreas tumor with tumor with rib destruction. C. RUL large and multiple small nodules of Wegener's granulomatosis. D. RUL 50. E. RUL lung primary and SVC obstruction of the superior vena cava results in impaired venous drainage of the head and neck and upper extremities. Clinical manifestations include facial and neck swelling, distended neck veins, headache due to cerebral edema, dyspnea, stridor and altered mental status. Cancer is the most common underlying cause of superior vena cava obstruction, and this includes lung cancer, mediastinal tumors, lymphoma/lymphadenopathy, and mesothelioma, either directly or through malignant mediastinal lymphadenopathy. Other causes include catheter-induced iatrogenic SVC obstruction, fibrosing mediastinitis, and Behçet's disease. Chef S. ETAL superior vena cava obstruction evaluation with MDCT. AJR AMJ Rentgenol. 2010, 194, W33646. 51. B. Angiodysplasia. The clinical RUL lung primary with retrosternal goiter. E. RUL lung primary and SVC obstruction. 51. A 63-year-old man presents to his general practitioner having noticed recent lower gastrointestinal bleeding. While waiting for his outpatient appointment, he experiences massive lower gastrointestinal blood loss. The patient is unable to have a colonoscopy and is sent for an urgent angiogram. This demonstrates patency of the major mesenteric and celiac vessels. An abnormal tuft of vessels with early filling of the accompanying mesenteric vein is noted at the cecum. No associated mass was seen. What is the most likely diagnosis? A. Ischemic colitis. B. Angiodysplasia. C. Hemorrhoids. D. Colon carcinoma. E. Diverticulitis. Chapter 11. 11. Test paper 6, questions. 314. 52. (52) An ultrasound scan performed on a patient with spinal trauma demonstrates features of a neurogenic bladder. Which of the following features are most commonly encountered? A. Thin-walled bladder with decreased capacity. B. Entirely normal bladder. C. Thin-walled bladder with increased opacity. D. Trabeculated bladder with increased opacity. E. Trabeculated bladder with decreased capacity. 53. A 40-year clinical history and findings on angiogram suggest angiodysplasia. There is no history of atherosclerosis elsewhere to suggest ischemic colitis. The major mesenteric vessels are usually patent in ischemic colitis. The exception to this rule would be in a case of possible superior mesenteric artery obstruction. Angiodysplasia can be part of the hereditary hemorrhagic telangiectasia syndrome. The condition results from a chronic intermittent obstruction of the veins where they penetrate the circular muscle layer of bowel. Distorted dilated vascular channels replace the normal mucosal structures. Endovascular treatment is an option. The findings on angiography do not point to colon carcinoma, diverticulitis, or hemorrhoids. Hastings G.S. Angiographic localization and transcatheter treatment of gastrointestinal bleeding. Radiographics. 2000, 20:1168. 52. Trabeculated bladder with decreased capacity. Neurogenic bladder can be caused by meningomyelocele, spinal trauma, diabetes, multiple sclerosis, polio, and herpes infection. It is a heterogeneous condition. For example, it can cause incontinence owing to detrusor overactivity, difficulty in passing urine owing to detrusor underactivity, or retention with overflow incontinence. Most commonly, the bladder eventually becomes trabeculated with decreased capacity, but very large atonic bladders can also be seen. The detrusor muscle is innervated by the sympathetic nerves originating from S2, S4, therefore, neurogenic bladder is a common problem in spinal trauma. Indwelling urethral or suprapubic catheters may be seen, and can be associated with stone disease and infection, including pyelonephritis. Treatments that may be seen on imaging include urinary diversion and continent pouch formation. Brantwe, Helm C.A., Fundamentals of Diagnostic Radiology, 3rd ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2000. "40-year-old golfer presents with sudden onset right medial palmar wrist pain during a golf swing. On examination, he has paresthesia in the right fourth and fifth digits. Plain AP and oblique radiographs are normal. Which of the following is the most appropriate next investigation? A. Nerve conduction studies. B. CT scan of the wrist with 1 mm slices. C. Hook of Haymate radiographic views. D. MRI of the wrist. E. Ultrasound scan of the wrist. 54. All of the following statements regarding praesacral mass lesions in children are true, except A. Anterior sacromeningocele is associated with Marfan syndrome. B. Rectal duplication cysts are high signal on T1W images. C. Tailgut cysts have high mucin content. D. Dermoid cysts have areas of high T1W signal, suggesting fat. E. Rectal duplication cysts may mimic lymphatic malformation. 2006:899, Dannert W., Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011:960. 53. D. MRI of the wrist. The patient's presentation is a classic description of a hook of Haymate fracture. These often occur during racket, bat, or club sports. A fracture of the hook of Haymate can narrow Guyon's canal, compressing the ulnar neurovascular bundle and causing distal neuropathy of vascular compromise. Conventional radiographs, even with multiple dedicated views, only have a sensitivity of 72% for diagnosing this carpal fracture. CT with multiplanar reformatting would be a reasonable next investigation. However, in view of this patient's neurological signs of ulnar nerve compression, MRI is the imaging modality of choice. This gives better soft tissue definition while still having a sensitivity and specificity approaching 100% for diagnosing fractures. Powell A. Haymate fracture. emedicine.medscape.com/article/97813-overview accessed on March 16, 2017. Chapter 12. Test paper 6, answers. 344. 54. B. Rectal duplication cysts are high signal on T1W. T1W images. Anterior sacromeningocele may be accompanied by other anomalies or syndromes, too, including uterine, renal, and bladder malformations, Marfan syndrome, and type 1. Neurofibromatosis. Benign sacrococcygeal teratomas are predominantly cystic, have attenuation similar to that of fluid on CT scans, and may include bone, fat, and calcification. Cystic areas typically have the appearance of fluid on T1 weighted and T2 weighted MR images. Areas of fatty tissue demonstrate high signal intensity on T1 weighted images, whereas calcification and bone are depicted as areas of signal void. The coccyx is always involved, even in benign sacrococcygeal teratoma. Malignant teratomas have a predominant solid component, and hemorrhage and necrosis are common. Enteric cysts are rare and may arise in locations between the rectum and sacrum. They are classified according to their histologic basis as either tailgut cysts or rectal duplication cysts. Duplication cysts on MR imaging demonstrates well-marginated, thin-walled lesions with low signal intensity on T1 weighted images and high signal intensity on T2 weighted images. Mucoid. Contents of tailgut cysts cause them to have high signal intensity on T1 weighted images. On MR images, cystic lymphatic malformations appear as areas of homogeneous high signal intensity on T2 weighted images and have the signal intensity of fluid on T1 weighted images. A fluid level can be seen in the setting of acute hemorrhage. Malformation. 55. A 5-year-old girl with history of seizures and learning difficulty is referred for an abdominal ultrasound due to nonspecific abdominal pain. On imaging, you notice bilateral renal cysts and multiple hyperechoic lesions in the kidneys and spleen. The patient also has small red skin lesions on her face. What is the most likely unifying diagnosis? A. Sturge-Weber syndrome. B. Von Hippel-Lindau. C. Autosomal dominant polycystic kidney disease. D. Tuberous sclerosis. E. Fast syndrome. 56. A patient with hemorrhage. Coco glue M. Fresh DP. Pediatric praesacral masses. Radiographics. 2006, 26, 383357. 55. D. Tuberous sclerosis. The U.S. images suggest renal cysts, bilateral angiomyolipomas, and splenic hamartoma. Polycystic kidney disease. PCKD1 gene lies next to tuberous sclerosis gene TSC2, and renal cysts are common in TS. TS is an autosomal, dominant, inherited neurocutaneous syndrome characterized by a variety of hamartoma 2 lesions in various organs. Classically, TS demonstrates a triad of clinical features, VOC triad mental retardation, epilepsy, and adenoma sebaceum. Fast syndrome constitutes posterior fossa malformations, hemangiomas, arterial with HIV is admitted to the medical ward with shortness of breath. Admission chest X-ray shows diffuse symmetrical airspace change. There is no pleural effusion or mediastinal adenopathy. At what CD4 count would you expect pneumocystis gyrovesi to present as a potentially life-threatening complication? A. CD4 0B, CD4 50C, CD4 100D, CD4 200E, CD4 400. 50. Arterial anomalies, cardiac defects, eye abnormalities, sternal cleft, and supraumbilical raphe syndrome. Typically infants have large plaque like facial hemangiomas. Omioka S. ETAL pictorial review of tuberous sclerosis in various organs. Radiographics. 2008, 28, 7E32. 56. D. CD4, 200 knowledge of the CD4 count when reporting a chest X-ray in an AIDS patient is important as opportunistic infections present at different count levels. A CD4 count lower than 200 is regarded as indicating a potentially life-threatening complication of pneumocystis jirovecii infection. CD4 greater than 500, no risk of opportunistic infection. CD4 200 500, candidiasis, Kaposi sarcoma. CD4 100 200, P. girovecii, histoplasmosis, coccidioidomycosis, PML. CD4 50 100, toxoplasma, cryptosporidiosis, cryptococcosis, CMV. CD4 50, Mycobacterium avium complex, MAC. Dannert W. Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins. 57, a 64-year-old man presents with left lower quadrant pain. He is very tender on clinical examination, and an urgent CT scan with contrast is performed. The radiologist suggests that the findings are in keeping with epiploic appendicitis. Which of the following best describes the CT findings in epiploic appendicitis? A. Accordion sign. B. Caricolic fat stranding. C. Ascites. Chapter 11. Test paper 6, questions. 315. D. Mucosal wall thickening with air-filled outpouchings. E. Caricolic focal hyperattenuation with a central area of fat. 2011:468. 57. E. Caricolic focal hyperattenuation with a central area of fat density. Epiploic appendicitis is most common in the sigmoid colon or cecum, where the appendages are most prominent. Most cases resolve spontaneously in about 2 weeks. It is therefore an important diagnosis to make, as it does not require surgery. It can appear on ultrasound as a non-compressible pericolic hyperechoic ovoid mass immediately under the abdominal wall. The accordion sign is. Chapter 12. Test paper 6, answers. 345. Seen in pseudomembranous colitis on post-contrast CT, ascites is a non-specific sign that can be seen in a variety of conditions, including liver failure, trauma, and pseudomembranous colitis. Mucosal wall thickening with air-filled outpouchings is characteristic of diverticulitis. NGKS, ETAL CT features of primary epiploic appendicitis. Ur J. Radiol. 2006, 59:284-8. 58. C. Fat density. 58. A 16-year-old boy presents with recurrent urinary tract infections and an MRI urogram is performed. This confirms ureteric duplication. Which of the following is correct regarding ureteric duplication? A. The lower pole moiety inserts inferior to the upper pole moiety. B. The lower pole moiety is more likely to obstruct than the upper pole moiety. C. The upper pole moiety is often associated with an ectopic ureterocele. D. The upper pole moiety inserts horizontally and is associated with reflux. E. Calyceal dilatation is usually seen in the lower pole. 59. C. The upper pole moiety is often associated with an ectopic ureterocele. Ureteric duplication is seen in around 1%-2% of the population and is usually unilateral. The upper pole moiety inserts inferiorly and is often associated with an ectopic ureterocele, which is more likely to obstruct, causing upper pole calyceal dilatation. The lower pole ureter inserts horizontally into the bladder, making it prone to vesicoureteric reflux, which can lead to scarring and deformity of the obstructed kidney's lower pole. Intravenous urography may show poor or no function in the dilated obstructed upper pole. An MR or CT urogram may also demonstrate the drooping lily sign caused by the lower pole moiety being displaced inferiorly. Brantwe, Helm C.A., Fundamentals of Diagnostic Radiology, 3rd ed. Philadelphia, PA, Lippincott Williams and Wilkins. 59. A 25-year-old woman had radiographs of her pelvis and both her lower limbs following a road traffic accident. Although no fracture was identified, multiple incidental findings were observed, including bilateral posterior iliac horns, protuberant anterior iliac spines and rudimentary patellae. Which of the following is the most likely diagnosis? A. Osgood-Schlatter. B. Bipartite patella. C. Diastrophic dysplasia. D. Protrusio acetabuli. Wilkins, 2006:889. 59. Nail patella syndrome. Nail patella syndrome is a rare autosomal dominant disorder characterized by symmetrical mesodermal and ectodermal abnormalities. Radiographic abnormalities include bilateral posterior iliac horns in 80%, diagnostic, flared iliac crests with protuberant anterior iliac spines, genivalgum owing to asymmetrical development of the femoral condyles, prominent tibial tubercles, fragmentation/hypoplasia/absence of the patella, radial head/capitellum subluxation with dislocation of the radial head dorsally, short fifth metacarpal, clinodactyly of the fifth finger, scoliosis, and occasionally, mandibular cysts. Protrusio acetabuli and bipartite patella are not disease entities as such. They are radiological descriptions of the acetabular floor bulging into the pelvis and a congenital fragmentation or synchondrosis of the patella, respectively. Diastrophic dysplasia refers to severe rhizomelic dwarfism, and Osgood-Schlatter refers to rupture of the growth plate at the tibial tuberosity secondary to an apophyseal traction. Injury. Dannert W., Radiology Review Manual, 7th ed. Philadelphia, PA, Lippincott Williams and Wilkins, 2011. Raman D. Haslock. Acetabuli. E. Nail patella syndrome. 60. A 60-year-old woman with breast carcinoma presents with headaches. CT shows erosion of the right foramen ovale on bone windows. An MRI of the head and neck region is performed. Which of these options is a likely finding? A. Fatty infiltration of the left side tongue muscles. B. Fatty atrophy of the right masticator muscle. C. Vocal cord deviation. D. Swelling of the right side of the face. E. Sensory loss of the right lower eyelid and cheek. 61. A 5-month-old infant presents Haslock I. The nail patella syndrome, a report of 2 cases, and a literature review. B.R.J. Room et al. 1983, 22:416. 60b. Fatty atrophy of the right masticator muscles. Denervation and fatty atrophy of the pterygoid muscles occurs due to involvement of the motor portion of cranial nerve V supplying the muscle of mastication. This nerve runs through the foramen ovale. Lane FJ, ETALCT, and MRI imaging of the central skull base. Part 2. Pathologic spectrum. Radiographics. 1990, 10:797 821. 61b. Routine urinary tract ultrasound within 6 weeks. Recommended imaging schedule for infants younger than 6 months.